everyone. Before we get started, I just want to remind everyone that this session will be recorded. You can choose to turn off your video by clicking on the camera icon at the bottom of your screen. Most of this session will be dedicated to your questions. You can type your question in using the chat feature, but just remember the chat is visible to all participants unless you message myself or the Rocky Mountain MS Center directly. We're streaming live from beautiful Salida, Colorado. Thank you to everyone who's attending in person, and thank you to everyone online. We're here tonight to talk about MS with Dr. Anna Shah. I'm Kelsey Morrow, Education Manager for the Rocky Mountain MS Center, and I would like to thank the pharmaceutical companies who have provided patient education grants to support this series. Thank you to Bristol Myers Squibb, Genentech, and Janssen Pharmaceuticals. We'll be posting a link for our evaluation in the chat. And then also, again, near the end of the events, please take a moment to fill those out. It helps us improve the series and all of our other educational programming. This speaker series is just one piece of our educational programming. We have a variety of formats available, including both in-person and online, as well as most of our programs are available on demand on our YouTube channel as well. The next Conversations on MS event will be on August 25th with Dr. John Corboy in Grand Junction and on Zoom. We have a webinar discussing stiff person syndrome with Dr. Amanda Piquet on August 4th, and we'll be hosting an in-person only event in Granby on August 19th. Our Fall Education Summit will be a hybrid event on November 4th. We do announce all of these educational opportunities on our mailing list, so please be sure that you're signed up for that. Or following us on Facebook. You can also go through Eventbrite to sign up for notifications about our events. And now I'd like to introduce you to Dr. Anna Shah. Dr. Shah was born and raised in Chicago, Illinois. She attended the University of Missouri, Kansas City for both undergrad and medical school. She went on to complete her neurology residency at the University of Michigan, where she served as chief resident in her final year. She completed her fellowship in MS and neuroimmunology at the University of Colorado. She sees patients and other related disorders. She sees patients with MS and other related disorders of the nervous system, and has a special interest in women's health and family planning. And then I just wanted to make a note. We did have a lot of really great questions submitted today, so we'll get to as many of them as we can. We've kind of grouped a couple of them together. But you are also able to ask new questions, again, by putting them in the chat box, raising your hand. And then just to note that today's presentation is for informational purposes only. All decisions regarding MS treatment and medications should be discussed with your neurologist. With that, I'll turn it over to Dr. Shah. I think it should be on, and let me
Can you hear me? Yeah, okay. Hi, everyone. So I'll just go down the list of questions. If there's something that you have a follow-up question to in regards to anything we asked, raise your hand, type it in the chat. So we'll go ahead and get started. The first question I've got on my list is what kind of progression decline might a patient with relapsing remitting MS expect in the future, just generally speaking? And I think there's a question later on in my sheet about PIRA, and so I'll probably talk about those together. So when we talk about PIRA, which is PIRA, that's progression independent of relapse activity. It's this new term that seems to be, I don't want to say a hot term, but kind of a hot term that we're hearing a lot more about in MS research. And it's this idea of, is there progression outside of relapses? So there's some other conditions that we see in our field where we talk about NMO or MOGAD, where we say relapses is what contributes to disability, and in between relapses, there's no disability accumulation. MS is different. So in MS, we sometimes say we see relapse and then recovery to whatever degree people recover from their relapses, and then some progression in the background of that. And the question is, well, how do you assess that? Who gets that? How do we stop it, right? The three big questions. How do we assess it? We assess it currently, I think, really poorly. And one of the reasons for that is you can imagine everyone's aging, right? All of us are aging. We're aging right now during this talk. But the question is, how do you differentiate what is pathologic related to MS or prior lesions in the brain and what is just natural aging. You hear people say, hey, as I get older, people without MS might even say, I have difficulty figuring out what word I want to say. We also hear this commonly in MS patients. And how do you differentiate the two? And the answer is it's really hard to do that. So that's one of the reasons why we see so much controversy around this term. It's just, it's really hard to differentiate what is MS and what is progression, independent of this relapse activity in MS. The real question is, what do we do to stop it? And I think that's kind of the question that everybody wants to know. And really, it's everything you do to maintain general health, overall brain health, is what you do to kind of help as much with these side effects that come with aging and help with this progression component in MS. So that is things like eating a healthy diet, exercising regularly, right? Neither of those two things will ever be bad for you. Staying cognitively active, socially active, which everyone's doing to some degree here, right? But doing all of those things is really what contributes to success if we say, what are the tools we have in our toolkit to prevent that progression? So in general, when we say what else can we do, if we're talking about people that are in that relapsing, remitting stage of their disease, it's really saying, can I start treatment, right? And not only just any treatment, good treatment, because the key is, at least now in July 2023, we don't have a way of reversing damage that's already been done. And we know part of what contributes to progression over the long term is the accumulation of how many inflammatory changes you've had or how many lesions you have had. So making sure you don't accumulate any more becomes really, really imperative, even if those lesions aren't causing symptoms. So that was kind of a long-winded answer to that short question. But essentially, everyone progresses to some form, right? Everyone's worsening, everyone's aging. But it's what can we do to prevent that in the setting of a known neuroinflammatory condition like MS? One of the other questions that I think is kind of closely tied is, well, how do you diagnose and treat primary progressive MS? And that one's a little bit easier to answer, but a little bit more complicated. So with primary progressive MS, it's not as simple as saying, hey, I had this relapse, it got better, then I had optic neuritis, my symptoms lasted a couple of weeks, and then they got better. It's saying, when I reflect over the last year, over the last 2 years, over the last 5 years, I noticed this slow progressive worsening in my symptoms. It might be walking, it might be strength, it might be something else. And I have an MRI scan that also looks like MS. That's usually how we diagnose primary progressive. It's not as simple as I had a relapse and I get diagnosed tomorrow. So sometimes that takes a little bit longer. What are our treatment options? Really, the only treatment option I primarily consider for this diagnosis is an anti-CD20 therapy. So ocrelizumab or Ocrevus, which is an infusion therapy that you get every 6 months, is one of the primary mainstays for primary progressive MS. Now, that doesn't mean the landscape won't change over the next couple of years. There's other medications, including Bruton tyrosine kinase inhibitors, that are being studied right now as treatment options for primary progressive MS. So more to come, which is the exciting part, I think, about MS right now. But that's kind of the mainstay and what I would recommend at this point. The next bundle of questions I have are kind of on the opposite end of the spectrum, which is, when do you stop? So the couple of questions I have here, which I'll try and address each one of these, is how do you know when you've aged out? When can I stop taking my Copaxone? When can I stop my DMTs? And then there's one that says, well, I heard the new protocol is to wean patients off Gilenya after 55. I'm looking for resources to discuss this. And probably Kelsey or someone else can link Dr. Corboy's webinar that he did about this big trial they did looking at discontinuation of disease-modifying therapies in MS. It was a big trial called DISCO MS. And essentially the premise of that trial was to say, we're going to recruit individuals that are 55 and older that have been clinically stable without new relapses and have been radiographically stable, so without new lesions on MRI scans for the last 3 to 5 years, and we're going to randomize them. Half are going to stay on, the other half are going to come off. We're going to watch them for a couple of years and see what the differences are. And now one of the important pieces to note is that it was all comers. So it didn't matter if you were on injections, oral therapies, infusions, whatever you were on, you were eligible to be in this trial. And what kind of came from it, I think one of the pieces that's important to note is even though the inclusion was people over the age of 55, the average age of people in this trial that actually got enrolled and randomized was actually, it was either 60 or 61. So a little bit older than 55. The way this trial was set up, and again, you can watch Dr. Corboy's, I think like hour and a half talk on this. The way the trial is set up is as a non-inferiority study. And what that means is it's different than our typical MS trials where we say, hey, we're trying to prove something better than something else. Here we're trying to say coming off treatment is not any worse than staying on treatment. And that becomes important because when you set up trials like that, the statistics get a little bit more complicated. So when they looked at the ultimate results of this trial, they found that from a clinical relapse standpoint, there wasn't a significant difference between the two groups, the people that came off and the people that stayed on. So they hit that non-inferiority margin that they had set up. However, when it came to MRI scans, they didn't quite hit it. They didn't not hit it, but they also didn't hit that margin. So they were left kind of in this gray zone. The real question is, what do we make of that? What do we do in real life based on those trial results? There's a secondary trial going on right now in Europe. Hopefully we'll get the results of that in the next year or two, where it's a very similar trial design. Their inclusion age is the age of 60, which will probably be a very similar demographic to what our trial was. So that'll serve as an additional point or an additional data point. But the real question when it comes down to when I'm thinking about coming off treatments, and this answer is different for everyone, so I would definitely talk to your neurologist about it. But the real question is, well, how long have I had MS? How long have I been stable? And what am I taking? So for example, if you're 54 years old, I'm not taking you off at the age of 55 because your body has already told me that it's capable of inflammation and it's going to cause damage. It's far too soon, right? It's a completely different story if you're 16 and you're 50, or if you were 16 at diagnosis and you're 55 now, right? So how long you've had the disease matters. When your last sign of disease activity was matters. Now that sometimes becomes complicated because the goal of a lot of treatments now is to say, we don't want new lesions. So how do you figure out, is it your treatment that's preventing you from having new MRI changes, or is it just that you weren't going to have them? And that's where it sometimes gets a little bit more complicated. Now, what I wouldn't do, because I think someone mentioned Gilenya, is there's certain medications that have this risk of rebound disease activity. So any medications that stop the immune system cells from doing the activity that's responsible in MS. So thinking about all of our sphingosine 1 phosphate receptor modulators like Gilenya or fingolimod, Zeposia, which is ozanimod, Mayzent, which is siponimod, and then which one am I forgetting? Ponvory or ponesimod, and then also thinking about natalizumab or Tysabri. All of those medications are sequestering or preventing those cells from getting to their target areas. So there is a risk of rebound disease activity with discontinuation. There have been some small studies that have shown even when people are clinically stable off of those medications, they can still have this rebound disease activity. Now, the chances of that are still less than the majority. So do people come off them and do totally fine? Yes. And I can only tell you how I approach it as a neurologist. In my practice, I usually say if you're on one of those medicines, I'll bridge you to something else before stopping you, because obviously you did these treatments for this long. You don't want to drop the ball at the end. Even if that chance is small, that's not what I want to do, and surely not what any patient wants to do. So that's how I tend to do it. Again, every neurologist practices differently, so that's probably a specific question to chat about with your neurologist, but that's kind of how I approach it. The next question is about developments in remyelination and what's the latest research on myelin repair. I'm sure most of you have heard about this trial called the Rebuild trial. which was a trial in which they said we have individuals, I think they had 50 people in the trial, individuals with optic neuritis, and we're going to treat half of them with an antihistamine called clemistine, and the other half didn't. And what they did was they measured those nerve signals through the optic nerves through something called visual evoked potentials, or VEPs. And what they found was there was a statistically significant improvement in those individuals that were getting clemistine compared to those that weren't. So that has gone on to kind of spurn a new set of trials. I think there's a couple going on in the US and a couple internationally, primarily in Europe, where they're looking at, well, if we do this combination of clemistine, an antihistamine similar to Benadryl, plus metformin, which is commonly used for diabetes, if we use the combination of both of them, are we seeing impacts on remyelination? Now, I think it's a little early to say, will that be effective? The good news is we'll know in the next couple of years. And the reason why I exercise some caution is one of the things we know with MS is when we have our nerve cells that are affected, not only can sometimes the myelin on the outside be affected, but so can the wires going through, so those axons. And so if you remyelinate or fix that outer insulation, but the inner axons are still damaged, you're not going to see that effect, even if you get the myelin reinstated. So I think it's important to think about it in that context. The other thing is, even if we see an improvement on tests, what matters the most is, are we seeing that change clinically? And that's what wasn't assessed, because that wasn't the purpose of that initial trial. What will be assessed, though, with these ongoing trials. So it'll be good to see, just because the number improves, you definitely want to see that improvement clinically for us to say that makes sense to do. So more to come on that, but exciting, because we don't have a lot of phase 2 clinical trials that are positive. So certainly something worth keeping all of our eyes on. Next question is new treatments. In the time probably since your last conversations, which I think was just a month ago, there haven't been any new treatments on the market. Now there are new treatments coming up. So there are several new treatments under the same umbrella being studied right now, called BTKIs, or Bruton tyrosine kinase inhibitors. Now these are all pills, and some of them are taken once a day, some are twice a day, depending on kind of how they work at a cellular level. The intention behind these medications, they've been around for a really long time, used really frequently in the cancer space. But what all of these medications do is they're stopping the signaling of a receptor called the Bruton tyrosine kinase receptor. And what happens with the signaling is we see this receptor on not only B cells, but we also see them on other cells in the immune system and in the brain, in the central nervous system, so macrophages and microglia. So the thought is, well, hey, if we're able to affect more than just those B cells, are we able to have added benefit or impact on that progression that's underlying, or kind of this smoldering inflammation that happens with MS? I would say potentially, we'll see. So there's 2 of those drugs. We'll probably wrap up phase 3 clinical trials at some point in the late fall, early winter. That's evobrutinib and tolobrutinib. And we'll see if we see as much oomph in the trial as we're hoping. The phase 2 clinical trials perhaps had a little bit less oomph than I would have liked, but potentially could be really promising for progression. So it'll be interesting to see, especially with the metrics they're testing in these trials. The main thing to pay attention to with these drugs is there have been more issues with liver side effects, so elevation in liver enzymes associated with both of these drugs. So with evobrutinib, there's been 2 cases where the liver enzymes have gone up and then they've gone back down once they've stopped. With tolobrutinib, there were several with liver issues, including one case that ultimately led to liver transplant and ultimately death. And so the biggest thing is we have to see kind of what will be the parameters that the FDA probably puts in place for these drugs. My guess would be probably regular liver screening tests frequently for the first several months of being on treatment, because that's when they tended to see these issues. But that'll just be something to keep an eye out for alongside with kind of what those trial results are. The next question I've got in here is what COVID precautions should a person with MS take if they're on B-cell depleting drugs at this point in the virus journey? And that's a loaded question, and I don't know that there's a right answer. And the reason I say that is I think we've transitioned to a point where we're seeing COVID become a lot more like the regular viruses that we see out in the community, without necessarily seeing as much of a correlation with death as we were seeing early on and with the Delta variants and things like that. So I would probably say I would err at this point at treating it similar to how we treat virus prevention as a whole. So for some individuals, and this is a little bit dependent on what else is going on in addition to being on these medications, in general, most people on B-cell depleting therapies might get more sick for a longer period of time, but should still recover. Anecdotally, I probably hear most people say, hey, if somebody else gets sick, maybe I'm sick for a little bit longer, but I get better. Things that could impact that in each individual patient, and this is a good conversation to have with your individual neurologist, is if your antibody levels are low, if there's another reason why you could be additionally immunosuppressed, or if there's issues with your overall white count because you came off another therapy that's caused lower white counts. Those kinds of things can predispose people to more severe infections or more prolonged infections. So it's a little individualized, but I would say kind of treating it with common sense, like washing your hands, not standing in front of someone who's coughing unless you've got a 2-year-old that coughs in your eyeball. Not that I have personal experience with that or anything, but kind of thinking with common sense.
Dr. Shah, I'll jump in with a couple from chat. Can you talk a little bit about how smoking affects MS?
I can indeed. Smoking's terrible for MS. Don't do it if you can, would be the quick answer to that. Smoking can make your MS about 6-fold worse. And we know that in individuals that don't yet have MS, it increases the risk of development of MS quite a bit. So there's all the other things associated with smoking, right? The lung cancer, the increased risk of strokes, heart attacks, all that other stuff that I'm not going to talk about. But as we're talking about it pertaining to MS, we see a higher rate of disability accumulation when it comes to not only smoking yourself, but exposure to secondhand smoke. So the way to think about it is you go through all this work, you're taking medicines, hopefully, to prevent disability accumulation, and it doesn't make sense to do something that's going to help you accumulate that disability quicker. So my vote is to avoid all smoking for individual patients, and then of course any and all secondhand smoke, and that should be something conveyed to individuals you live with, right? Because your loved ones also don't want you to become disabled quicker.
Do you have any information on Selma Blair, particularly what she's on or how she's doing?
Trying to think of how to answer this professionally. No, I don't. I would personally, speaking as a medical professional, take caution with everything you hear about celebrities and their MS status. And the reason I say that in particular reference to Selma Blair is I haven't watched her entire documentary. I've seen just snippets of it. There's several pieces of that I say as a neurologist, as a medical professional, there are things in there that are not related to MS. And I think it's hard because these don't get medically verified. And so I think she has other diagnoses going on that I won't go into right now. But I would take all of those things with a grain of salt, which is not the question you asked, but how I will answer it.
And then one more from the chat. Do you have any opinions on Mavenclad?
In what respect? As a drug? Any opinions about Mavenclad? And I'm not sure. It's an oral medication. That's one of the MS DMTs, but maybe we could ask that person if there's a specific.
I'll let you know when they chime back in.
Okay, that sounds perfect. I'll just keep going down this list then. The next question I've got on here is about a patient that said, I have a ton of spasticity in my left leg and feet. A podiatrist diagnosed me with arthritis in my feet. Is there anything I can do to help with these symptoms? When the contractions happen, they're really painful and often go all the way up to my hip. And I think this is kind of related to another question that I saw later in the list about the difference between Zanaflex and baclofen. So spasticity is essentially something that happens when you lose upper motor neuron control. And what upper motor neuron means is we have in our nervous system, we have our brain or spine, that's all considered central nervous system. Everything else is peripheral nervous system, including when people say, oh, I have a pinched nerve. Peripheral nervous system, when people say I have carpal tunnel, peripheral nervous system. By definition, MS does not affect the peripheral nervous system, only affects the brain and spine. However, what happens is you have a nerve cell from your brain and spine that links on or sends signals to a lower motor neuron or a neuron of the peripheral nervous system. When you lose that upper motor neuron disinhibition, you get spasticity, you get hyperreflexia, which is why probably most of you, if your knees have been tapped in the neurology office, you're like, oh yeah, that's a pretty quick reflex. With spasticity, it's usually in conjunction with weakness. So one of the things that's really important for both neurologists and patients to think about when we're thinking about how do we treat spasticity is saying, how do we balance spasticity and weakness? In general, when people are spastic, their muscles are tight. And you can imagine if you have ever used a cane or a walker, the reason those things are helpful is because they're stiff, right? If you had something that was like a cane but was floppy, it wouldn't be really helpful, right? Which is the equivalent of over-treating spasticity because then weakness would come out. And so one of the things to always pay attention to, which I know isn't exactly a question, but things that are important for everyone to think about, is when we're treating spasticity, making sure we're not over-treating the spasticity, causing someone to feel more weak. Now, that being said, there's lots of good treatments for spasticity that vary quite a bit. I think one of the biggest things that everybody can do that has spasticity is regularly stretch. The nice piece with regular stretching exercises is it's not going to give you all the side effects that medications do. And with stretching, doing it just one time a day isn't enough for the whole day. So the easiest way I like to think about it is if we say we're trying to do it 5 times a day. We do it in the morning when we wake up, with breakfast, lunch, dinner, and then before we go to bed. Regularly stretching helps prevent us from having to constantly play catch up with spasticity, which becomes really important. Now, it doesn't need to be crazy stretches. So if you're saying, hey, my legs feel tight, it might be a quad stretch, a hamstring stretch, and a gastroc or calf stretch. And it can be as short as just a couple of minutes several times a day. If you need help figuring out how or what stretching exercises to do, there's a really nice link on the National MS Society page for spasticity. There's also, you can also talk to your neurologist or physical therapists about it too, which can be really helpful. In terms of how to help with spasticity from a medication standpoint, there's a couple of different options. So if we're talking about pills you can take, baclofen and Zanaflex are probably the 2 most common ones we use. The other name for Zanaflex is tizanidine. Both of these medications don't last all day. So usually for most patients, unless you say you just have spasticity at night, they're usually something you have to take a few times during the day, which can be really challenging because the most common side effects associated with these are usually grogginess or sleepiness. And so the key with these medications is to start low and go up slowly so your body becomes adjusted to these medications. And then you can kind of pinpoint, hey, am I on the lowest dose? I need to make an effect on my symptoms. I tend to notice with Zanaflex or tizanidine that people have more sleepiness than they do with baclofen, but that's not true for everyone. I just tend to see that as a whole. They both are acting on different receptors in the muscles. So theoretically, you could take both simultaneously, but it's better to start on one and maximize one if you can, if you're not getting side effects before adding in a second agent. Other options for spasticity, which are a little bit more invasive than the stretching and then the pills, are things like Botox injections into the spastic muscles. The challenging piece with Botox is if you're doing it in the legs, most folks that are injecting Botox will go really, really slowly to start, again, because nobody wants to cause underlying weakness to come out. So it does sometimes take a little bit of time to find the right dose for individual people. The other more invasive option is to think about baclofen pumps, which is essentially you get a pump inserted that gets refilled with baclofen about every month to 3 months, depending on how much is used, and it goes directly into the spinal canal. The nice piece with that is you can get regular, consistent dosing of baclofen without getting all of the systemic side effects like sleepiness and grogginess. So that's kind of the whole gamut of kind of thinking about spasticity. But if you're not stretching, that becomes really helpful. And doing it small chunks regularly is really important.
On the Mavenclad question, they're wondering for the treatment of relapsing remitting MS, efficacy, side effects.
Yeah. So it's a good medication. So it's an oral medication. The question was about Mavenclad. Its other name is cladribine. It's an oral medication. I think the biggest positive piece with it is that you just have to take it once a year, and then repeat another round the next year, and then you have efficacy for a couple of years afterwards. We don't tend to use a ton of it at the university. There's been more data about efficacy over a longer period of time that's come out just about 6-ish months ago or so. That looks pretty good. I think one of the challenges with Mavenclad is it's hard to know when you're going to need another treatment. So I think in the setting that I think it has the best benefit personally as a neurologist is when people are de-escalating or thinking about discontinuation and using it as a nice bridge. I think it's a little bit more challenging in the younger population because then at least I personally struggle with when do you need another medication, or at what point will you need another DMT. But overall, a good medication. I will get through the next couple of questions, which looked a little bit more centered around pregnancy and breastfeeding. These questions were in a previous talk. I think you said you would recommend continuing DMTs at 4 weeks postpartum and breastfeeding. Can we get those therapies, in my case, Rituxan, and still breastfeed uninterrupted? And what should we do about postpartum care for new moms with MS? All really good questions. Things that become really important to think about when you're thinking about postpartum periods is what's going on with the body and what are our risks from an MS standpoint and what are the goals of moms in terms of breastfeeding. So if we're saying in general, what happens if we did nothing and we're looking at just the risk of relapses after someone delivers a baby? In the first 3 months postpartum, that risk of relapses goes up about 70% compared to when they were before conception. So there is this really high risk or high chances of relapses, either clinical relapses, like someone has new symptoms, or radiographic relapses, meaning there's new MRI changes in that first 3 months postpartum. Some of the earlier studies have quoted numbers up to 55%. So the majority of people have something happen. Now, if you are exclusively breastfeeding, which means breastfeeding or pumping about every 3 hours or so, that risk of relapses decreases by about half. Now that becomes challenging, right? Because not everybody is able to exclusively breastfeed or don't want to, which is also fine. So the question is, well, what else can we do to mitigate that relapse rate or that risk that we're talking about? So when someone delivers, and if they're planning on breastfeeding, the first type of breast milk you get is something called colostrum, transitions into transitional breast milk, and then transitions into mature breast milk. Mature breast milk usually comes in on average around day 10 to 14 for most women. So most of what we know about how drugs pass into breast milk is in that mature breast milk phase. So when we're thinking about how do we do these medications safely, typically dosing at 4 weeks, which may be overly cautious, although to be totally transparent, all of the FDA submitted drug information says do not breastfeed on any of these treatments. It's if we're thinking about, well, how do these drugs get into breast milk? The larger molecules, so medications like rituximab or ocrelizumab or ofatumumab or natalizumab, those medications are larger molecules, so the passage into breast tissue is limited. There's been several studies, particularly for rituximab, since that's what the question was about, not only in MS, looking at concentrations of rituximab in breast milk, but also in GI, in rheumatology, in oncology, because rituximab is obviously used for a broader application than just MS. And what they really find is that the amounts of rituximab that pass into breast milk are far, far, far below what the FDA considers acceptable. The other thing to think about is when babies taking breast milk in by mouth, if it was a medication that was orally available, we would give it as a pill, but the reason we give it through an IV is because you don't absorb it well. So the babies also got this second stopgap. One of the studies that we did here last year was checking B cell levels in infants that are breastfeeding in moms that are taking some type of B cell depleting therapy. And all of those infants had completely normal B cell counts. There is also an ongoing study right now that'll probably wrap up in the next couple of months, where they're looking at ocrelizumab in moms that are breastfeeding and looking at infants' blood counts and also looking at infants' responses to vaccines. That should be something that's out in the next couple of years as well. So with all of that being said, I think there's a lot of data that points to safety. Again, have a conversation with your neurologist, but I personally think it's okay. Other things postpartum is the postpartum period can be challenging. So thinking about how do I make sure I get enough sleep, that my stress levels are down, all the things that people want to do, but is challenging to do, but starting to plan for those even before getting into that postpartum period are just important to protect your brain health. Going to the other end of the spectrum, there's a question about menopause and does menopause worsen MS? And that one, the answer to that, the short answer is maybe. The data is kind of conflicting about menopause in MS. Older data sets used to show that we use this scale to assess disability called the EDSS. And that's a scale that's very heavily weighted on how well someone walks, or if they use something to help them walk, or how far they can walk. But older studies showed that individuals that were going through menopause had an increase in their EDSS levels, so a slight worsening in disability around that time of menopause. What we found since then is there's another study that's come out that says, no, we're not really sure we see that. I think one of the reasons we see all this conflicting data is just the fact that we have new treatments. We're in a different treatment era. So it's hard to kind of take information from an era where we were studying individuals not on treatment or on poor treatment, and comparing that to today's individuals. The average age of menopause in women with MS is the same as women without MS, so around 51 and a half years. And I think there was a question about this later on about using something for menopause. I want to say it was like Gabapentin or something like that. Okay. The question is, can you also use Gabapentin for menopause? You could, but there was actually just a month ago a new medication approved for hot flashes through the FDA. It's called Veozah, VEOZAH, I think. If you search that with FDA approved hot flashes, if I'm spelling that wrong, it'll correct you. But I think it was just approved in May. So that might be a good option. The other options too that are out there is thinking about hormone replacement therapies, which if done properly by a properly trained physician, it can be very safe. I think they got a bad rep with some of the bigger original trials that came out unrelated to MS. But I think if used properly in the context of MS, they can actually be really safe. One of the most challenging parts about menopause is the most common symptoms that you hear women overall say is they have hot flashes and their brain feels foggy, which we say, well, we know heat in MS doesn't really help symptoms. And we know the brain fogginess already sometimes happens. And so kind of thinking about, well, what can we preemptively do to minimize that? And it's thinking about, well, how do I want to balance quality of life, right, with the symptoms I'm having? So that would potentially be something I would consider over gabapentin in terms of having better side effects. Thinking about the Veoza or even targeted hormone replacement therapy, but again, making sure that you're seeing a properly credentialed physician to do it appropriately, because there's a lot of people out there that don't do it appropriately. The next question I've got is, how do you keep brain health and cognition? Already exercising, healthy diet, sleep, meditation, yoga, qigong, what really works? All of those work, and all of those in combination are better than doing any one in isolation. So things that we know, in addition to all of those things that I already mentioned, right? Healthy diet, good sleep. There was a recent study that came out, again, unrelated to MS, but related to neurology, where they showed chronic sleep deprivation put individuals at higher risk for developing Alzheimer's. So thinking about good sleep, diet, regular cardiovascular exercise, all things recommended by the American Heart Association for good heart health, it's going to be good for brain health. The other thing I would add to that is making sure you're regularly exercising your brain. We talked about exercising your body. What does exercising your brain look like? In most people's cases, and I am guilty of this as well, I mean, you've got your phone. It's really easy to scroll and just kind of just mindlessly do that, right? What you're doing when you're doing that is you're turning your brain off and you're not actually engaging your brain. What counts as engaging your brain? It's picking up things that are hard for you to do cognitively. For some people, that might be, hey, my work is really challenging and I'm exercising my brain the whole time I'm at work. And I say that's fantastic. For other individuals, it might be, well, I've done my job for whatever number of years. It's pretty easy. What else can you do? It's thinking about, can I pick up a new hobby, right? Learning new languages, learning new instruments, learning new tasks like crocheting. If you say, hey, I have an issue with my fine motor, maybe even picking up like Lego sets and using your brain to construct those while also working on fine motor activity. All of those things where you're like, oh, my brain feels kind of tired, that's exercise of your brain, right? It's the same thing. If you're just sitting there and you're like, okay, I'm going on a walk, I don't feel winded, I don't feel like I did anything, I'm not actually exercising, I'm just walking, right? It's the same thing for your brain. If your brain doesn't feel like something is hard and you're not exercising it, the more you engage your brain, the stronger of a muscle your brain becomes, the less likely it is to atrophy. Which I've probably said this in prior talks. If you're a patient of mine, you've definitely heard it. But everyone's brain starts shrinking at the age of 30. So most people, by the time they get diagnosed, their brains are already shrinking. The MS certainly helps accelerate that. So we, as patients, have to think about what can we do to make sure that that doesn't get there. This other question is, what do you recommend for good cognitive support, which I think we already hit on. I don't know, Kelsey, if it would be worthwhile linking that. There's like a brain health talk that was done by someone who wrote a book. I can't remember who that was, a couple years ago, maybe linking that. I think it was from a patient with MS talking about what they kind of did to help support.
That was Jeffrey Gingold, and yeah, we'll link it in the chat.
Would be a good one. The next question I've got is sushi good for an MS diet? And I don't know that I have a strong opinion on this either which way. I don't think there's been any studies about sushi in particular with MS. The only thing to watch out for in general is sushi can sometimes be salty, or if you're dipping it in a lot of soy sauce, there's a lot of salt there. What you want to always make sure is we see this higher chance of comorbidities like high blood pressure associated with MS. And we know that can help with MS progression. So being mindful of sodium intake would be kind of what I pay most attention to with that, but I'm not sure I've got a better answer than that. Oh, the question about gabapentin, other than perimenopausal symptoms for nerve pain. Really good question. And I'll try not to be super long-winded about this one. There's different medications that can be used for nerve pain. And I would classify them into maybe 4 different groups. There's the topical agents, so things like creams, lotions you can put on. Those are usually lidocaine cream, and then capsaicin cream, which is a chili pepper cream that you want to be really careful with washing your hands thoroughly after using. And then within the medications category, probably the 3 most common buckets that we think about is the gabapentinoids, which includes gabapentin and then Lyrica or pregabalin. Then there's the SNRIs, which includes duloxetine, which is Cymbalta, and venlafaxine, which is Effexor. And then the 3rd bucket is your tricyclic antidepressants, which is nortriptyline or Pamelor, and then amitriptyline or Elavil. And usually one of those 3 buckets is kind of where we start. Gabapentin, I think, is a good medication. If it's working, it's working. One of the most challenging parts with gabapentin is just how quickly it leaves your body. So again, kind of similar to how we discussed the baclofen and tizanidine earlier, if you say, hey, my nerve pain is most prominent at night when I have nothing else going on and I have nothing to focus on other than my nerve pain, then you could use it just once a day. But otherwise, in people that have chronic nerve pain, it's usually that you have to dose it multiple times a day to get the same therapeutic benefit. Biggest side effects that I see with gabapentin is usually grogginess or sleepiness. So if you're a patient that already has fatigue as part of your MS, sometimes it can kind of be counterproductive. But are there people on gabapentin that say this made a world of a difference? Absolutely. My bias is saying, well, how do we hit as many birds with one stone as we can? So if I've got patients that have anxiety or migraines or kind of non-specific muscular pain or a history of fibromyalgia, sometimes I'll lean more towards the SNRIs because those will work on that plus the nerve pain. Or if I've got individuals that say, hey, I have a challenging time sleeping at night, plus I've got the nerve pain, I might lean towards the tricyclic antidepressants. Or if someone's already been started on gabapentin and they say, yeah, it kind of works, but maybe I just need more oomph, then we'll usually build on what they're already on rather than throwing something new into the mix. But it's a good medicine when it works. The challenges with these is not everyone responds to these medicines all the same. So some people will say this is a miracle medicine, other people will say I hate it. And we don't have a way of knowing who's going to say what until you try it. So sometimes it's a little bit of a see what sticks, which feels really unsatisfying at times. But it's good when it works. And if it doesn't work, there's lots of other options.
Does MS specifically make people more sensitive to medications? One person has tried both gabapentin and baclofen and had horrible side effects. Wondering if that's MS related.
No, MS does not make you more sensitive to medications. I would say important things to think about is if you're more sensitive to medications, what is the absolute smallest dose you can try of a medication and how are you taking it? And the reason I say that is because I've seen some patients that have come in and said, oh, hey, I started on this, not an inappropriate amount of baclofen or gabapentin, but if you start it all at once, you might get more of those side effects rather than letting your body feel more comfortable with it and kind of accommodate for those side effects. The other thing that becomes important is, are you taking it consistently? So if you're taking the medications intermittently, you have more of an up and a down in terms of bloodstream, so you tend to have more pronounced side effects, versus if you're taking it consistently, you get more of a steady state. but having bad side effects to either one of those two medications is not unheard of. And there's other options out there that might not make you feel the way you did, like some of the other ones I talked about. Oh, are there any muscle relaxing medications that do not exacerbate fatigue? No. Would be the short answer of that if we're thinking about pills. Now, we talked about those two other interventional options, like the Botox and the baclofen pump. Those should not affect your fatigue levels, and then stretching won't affect fatigue levels. But the pills, they tend to make fatigue worse. But again, where I tend to see more of that is if we haven't started really slowly and if you're not taking it consistently. So even in my patients that are taking it once a day, you're still getting this up and down because those medications are well outside of your body before you take your next dose. So if you're getting all these peaks and valleys in terms of drug levels in your blood, you're more likely to feel some of these side effects. So as counterintuitive as it sounds, sometimes taking lower doses more frequently during the day can actually help with that fatigue. The next question is about best pain reliever for foot neuropathy, which I think we've already talked a little bit about. The question was, does Tylenol? So Tylenol, ibuprofen, those aren't going to work for nerve pain. Opioids aren't really going to work for nerve pain. They might work transiently, but really for nerve pain, you need one of those medications I talked about, because the other ones aren't really going to do that optimally because they're not working on the receptors that conduct nerve pain. Another question about achy burning feet, but I think we talked about that one. The next question is about latest studies on complementary treatments. There's always a lot of these. They tend not to be as big of trials because their funding, I mean, trials are very expensive and they don't have as much funding as some of the drug trials do. So with complementary medicine, I say we take everything with a grain of salt. Especially if it's someone trying to sell you something. They say, hey, X, Y, or Z works, and also here, I'll sell it to you. But I think that's the approach for everything to think about. The studies that are being done right now, so they've done a couple looking at supplements like alpha lipoic acid. They did one on CoQ10. And none of those have turned out to be positive studies. Other complementary things that I would think of that maybe doesn't have the data behind it, but kind of does. So I'm a big fan of acupuncture or dry needling for my spasticity patients if they feel like it helps them. The challenging piece is whether it's covered by insurance, it is a hit or a miss. So I don't want people to go get it because there's data behind it to actually help that. But if you get it and it helps you, then I would continue doing that. Acupuncture can also has some decent data behind it for anxiety and depression, which we see really frequently as a comorbidity in MS. So I would consider that a nice adjuvant if that's something you're interested in. I think there was a question about biofeedback and kind of thinking about that. The data, there's some not great data about biofeedback as it relates to nerve pain. So I don't know that I necessarily buy that it's effective for that. There is good data about biofeedback as it relates to mental health, as it relates to depression and anxiety. So that would be one of those things where I would say, gosh, the risks associated with that are pretty small, right? If it helps, then that's fantastic. And so that might be one area to think about that in. I'm trying to think about other complementary medicines. There's a huge push of like these mushroom powders and all of this stuff right now as it helps with cognition. Data behind that is very, very scarce. I don't know that I buy it. What I usually say is, if you try it and it helps you, great, then keep taking it. But again, there's no data behind these for me to say, go out and get it. because it will help. So if something symptomatically helps, we're not gonna complain about that, but don't feel the need to go out and spend all this money on these things because there's data behind it.
I have another one from the chat. Are there effective treatments for pseudobulbar effect? Are there lifestyle actions that affect the degree of intensity of PBA activity? Things like hunger, diet, food choices, fatigue. Do any of those make it worse or better? And then can you explain what that is also?
Yeah. So PBA pseudobulbar affect is kind of the sense of having inappropriate reactions, like inappropriate laughing or crying or things like that. There's actually a medication. So we tend to see that not as much in MS, but in some of the other neurologic conditions that other neurologists treat, not so much us in neuroimmunology. There is an FDA-approved treatment called Nudexa for pseudobulbar affect. So that would be kind of what I would target. Can you see individually if there are cues and you have a relationship with those cues? Of course. But one of the things with PBA or pseudobulbar affect is there isn't necessarily a trigger, which is why it's crying or laughing at inappropriate times is kind of what we think about as the definition. So track it, sure, but don't drive yourself nuts trying to track it, because I don't know that it'll always be consistent, like in terms of it always happens when you're hungry or something like that. Anything else, or should I keep going? Okay. This next question, I'll read the whole thing for context, and then I'll answer it. But it says, hematopoietic stem cell transplant for MS has been around for 20 years, but is only now gaining widespread traction in much of the U.S. neurology community. Still, though, health practices performing the therapy in the U.S. seem to require a Goldilocks of disease progression before qualifying a patient for treatment, demonstrated degradation while on DMTs, but still in reasonably good shape. Why isn't it more widely talked about and available? Why should someone have to wait until their symptoms get worse before being eligible, especially because morbidity rates are on par with hip replacements? Good question. A lot of that is because the data isn't there. And what I mean by that, so there was a study that came out within the last 3 months. I can't remember exactly when it came out, but they were essentially saying, well, hey, let's compare the outcomes of individuals that get stem cell transplants and compare them to a couple of different therapies. I think they compared them to Gilenya, so an oral medication. I think it was Tysabri, and I think ocrelizumab or Ocrevus was the third one. And they really found, especially comparing it to Ocrevus, that the outcomes were very similar. And so when we think about why we do these treatments, right, we're doing them for efficacy, right, of shutting down inflammatory activity, but doing that while we can minimize side effects. The rates of death with stem cell transplants are multiple fold higher than infusions like Ocrevus. So then my question is, if I'm seeing outcomes that are at the same rate, but one has significantly higher risk, which I would consider death to be a pretty significant risk, why would I do that unless I have better data in terms of long-term outcomes? There was a paper that came out a couple of years ago where they looked over the course of decades, I think, at stem cell transplants. And it's a little bit harder to make meaningful choices based off of this paper because, of course, stem cell transplants, just like our treatments, have advanced in terms of how well they can do it without having that risk of death. But really what they found was, I think it was either 10 or 15-year rate of new disease activity. So about 65% of people had all complete cessation of disease activity at that 10 or 15-year mark. I'm sorry, I can't remember how long it was. But that's far from a significant majority, again, to think about those risks. So I would hope that all of you are seeing neurologists where you're not doing the Goldilocks approach, because I think that might have been the way it was, but it certainly shouldn't be the way it is now. And my hope would be, or I guess my personal opinion, is I'm going to do things that give me the best benefit while minimizing side effects. And I have not seen anything that tells me that stem cell transplants are better than we've got that's best on the market today. Now, if you're saying stem cell transplants compared to an oral medication or something like that, yeah, stem cell transplants are going to be better. But I think it depends on what you're comparing to. There is a trial right now called Beat MS that's going on. I think it's going on nationally. It's run primarily out of the Cleveland Clinic, but if any of you are in the Denver area, we do have an enrollment site where they're comparing stem cell transplants to high efficacy therapy like Ocrevus. It's a trial that still hasn't finished recruiting. And a lot of it's because you're just not seeing the people eligible for recruitment, because most people do really well on high efficacy therapy. Now, not everyone does, right? It's not 100% efficacious for everyone. So is there still a role? Of course. But I think just like everything else in medicine, it's about balancing what are the risks and side effects, and am I getting a greater benefit than potential risks? And then the next question, how do you know what medicine to start taking? Doctors are giving me choices. Which one is better? That is a loaded question. I don't know that I could answer that probably to the degree that whoever asked this wants me to answer it. I would say, just like everything else in life, if you feel like you're getting a lot of choices and you're not getting the guidance you want, seeking a second opinion is never a bad choice to get another set of opinions. The medications that we tend to start with here are high efficacy therapies. So those are things like B-cell depleting therapies, as well as natalizumab, I would put in that category. And a lot of that is because we talked about progression right at the start of this discussion. When you accumulate lesions, they stay. Some of them smolder, but you don't know which ones are smoldering unless you took a piece of that tissue and looked at it, which no one should be doing. But the question is, well, how do you shut down any and all inflammatory activity? And the way you do that is with good treatment. So if you've got a gamut of choices, my bias is always going to be towards those highly effective ones. Those give you more bang for your buck if done in the first several years after diagnosis, rather than doing them later on, because your inflammation eventually burns itself out. So you want to use your strongest weapon when you can. So that might not be a great answer, but we'll leave it there. We'll jump forward to the question about psilocybin as it relates to MS. And so not really any data, right? Because it wasn't legal for a while as it relates to MS. Now, where there has been data is thinking about psilocybin as it relates to depression and anxiety, mostly depression. The data for that is actually pretty good. Again, small numbers. I'm sure we will see a significant expansion in that data in the next couple of years now that there's more access to it, especially in Colorado. What I don't know is, will that do anything from an MS perspective? I think the one tiny study I've seen about it was that it didn't have an effect on MS relapses, which I would say would be like the bare bones starting point. But I don't know that I've got a ton of science or data to back it up. I might say, I would probably put it under the same realm of kind of where I think about ketamine in terms of thinking about depression. If it's something that helps your depression, we know one of the biggest things that makes MS worse is all these comorbidities. Depression, right, makes everything worse. It makes blood sugars worse. It makes blood pressure worse. There's absolutely no reason it can't make MS symptoms worse, like fatigue, pain, cognitive thinking. And so if the depression is playing a huge part, is it worthwhile thinking about exploring that psilocybin? Yes. I don't know that I have enough data on it from a disease modification standpoint that I can make any other significant, intelligent thoughts on that. But if there is a more specific question, let me know. So the question was, is it dangerous to do it with your current DMTs? The short of it is, I don't know. I probably have to explore. So I don't know enough about this, and I'll be the first to admit it. But the biggest thing I would think about is, could there be an impact on kidney or liver function? I would think about more liver function would be my gestalt. Again, I don't have, that's just a pure guess. So it'd be just thinking about what is the interaction between different drugs and the mechanisms that clear out drugs from our body would kind of be where I would worry most about that interaction. With the infusions, I wouldn't get too worried about that particular mechanism, but I definitely would with some of like the oral medications that are used in MS. But I don't know for sure. So THC, so that one I can actually answer. So with THC and CBD, there is not a known interaction between any of the MS medications in terms of disease modifiers and their use. Now, I will leave this caveat out there. There was a small study, and there will be larger studies as it is more nationally available. A smaller study that showed chronic THC exposure increases how fast your brain shrinks. Now the question is, what is it? What amount does that? And that's the answer, or the question that I don't know the answer to. So in most cases, I say, well, let's see if we can minimize THC use. There hasn't been any association seen with CBD and increasing brain atrophy, but that's something to think about. There was a study that we were going to do at the university looking at an oral spray that had a combination of CBD and THC for spasticity. It got shut down before they even finished enrolling, and that's because they didn't see any difference. And I think that's what we've consistently seen with THC and CBD products is patients say it makes them feel better, but we don't actually see that in an objective way, which is always challenging, right? Because if something makes you feel better, it makes you feel better, right? But I think it's, again, thinking about risk benefits. I don't know that we've got a quantifiable risk with THC that we can say, this amount. I mean, we also see that with regular alcohol use, that also helps atrophy your brain. So it's saying, well, 6 of one, half a dozen of the other. How do you figure out what's what? But limiting it if you can, just based on that small study, but I bet we'll have bigger studies to come. This question, should treatments be personalized based on medical history or particularities of presentation? If so, what do you think of the progress in exosomes therapy? Treatments should always be personalized. And that's one of the reasons why there's not a one size fits all for all MS patients. So definitely should be personalized to a degree, I should say. But I'm not sure that there's been a ton of actual progress in terms of exosome therapies in any meaningful way in MS. And I'm not sure that there's a ton of attention to it unless there's small studies going on somewhere that I'm just not aware of. But certainly not something that seems to be mainstream. And I'm not sure it seems to be where the field is going right now. Because I don't know that we would need personalized exosome therapy to affect the majority of people, because the majority of people respond to the therapies we have on the market. So I'm not sure there's actually a need for that. But I'm happy to look into it and see if there's something I'm missing. Um, the next question is Briumvi just came on the market this year to treat MS. How are patients overall responding to this medication? What is being developed in new medications? I think we already touched on the new medications. Briumvi, so that's a new medicine that just was approved in December of last year. Its other name is ublituximab. It's also an anti-CD20 therapy. So it's got the same class effect as Ocrevus, rituximab, and then also ofatumumab or Kesimpta. I think most patients are responding well, which is not a surprise because that class of medications works well. I don't know that I've got a ton of data on it, mostly because it's not on our formulary yet at the University of Colorado. So we can't actually prescribe it yet. But from what I've heard from the community doctors or the community neurologists that are using it, they're seeing similar efficacy patterns, and that's kind of what the trials have shown us as some of these other CD20 therapies. If there was a specific question related to that, just put it in the chat so I can answer it better. The next question is, how long is it safe to take dimethyl fumarate or Tecfidera? I've been on it for over 10 years. No relapses or any problems. I'm 63, diagnosed in 2006. Well, theoretically, you could take any medication for as long as you want. The biggest thing to watch out for with long-term Tecfidera use is sometimes we see lymphopenia or a drop in white blood cell counts with prolonged use. So that's one thing to keep in mind. The other question is, do you still need it? And again, a question that's probably a good discussion with your neurologist, but it becomes important because are you risking side effects without getting benefits? We know MS, the inflammatory piece of MS, which is really what medicines like Tecfidera are addressing, those kind of have a limited lifespan in MS, meaning that most people after 5, 10, 15 years will have a significant drop off in those inflammatory pieces of MS or the propensity to have relapses, whether it's clinical or radiographic. And so the question is, do you still need it? Would be kind of my question back to you. The next question, I think I've only got a couple left. I'm doing good. Is a 76-year-old who was diagnosed 25 years ago. She was on Ocrevus 5 years ago, had a terrible reaction. Now I'm progressing. My neurologist doesn't want to give me anything. Do you have suggestions on what I can do to stop progression? Good question. I guess it would depend on what your reaction was to Ocrevus. I would say if we're thinking about progressive MS, I would probably say Ocrevus is an okay medication, but okay is kind of the best of what we've got. I would say probably less than 50% of my patients actually have a significant change in their progression while on these CD20 therapies. So I don't know that you're completely missing the boat, right? If you had a bad reaction on this type of therapy, you could think about something else in that class. Or just know that it's not necessarily a silver bullet. The biggest things with progression is what are these other things that are making progression worse? So one of the things that we see concurrent with progression in MS is significant amounts of deconditioning. And what that means is if I said, hey, my right leg is weak because of my MS, what I will tend to do subconsciously over time is favor my left leg. So I will use my left leg muscles less and less. And the less I use them, if I don't use them, I lose them. And what happens with musculature, especially as we age, especially for someone in their 70s, you can have just the slightest change in activity and you lose those muscles, and it takes a really long time to get them back. And one of my favorite studies, I think, that demonstrates that is they put a bunch of football players in the ICU for a week, and they weren't ill, but these are all people that are in fantastic physical shape. And they found that it took them several weeks after leaving to get back to where their performance was. And that just kind of illustrates how quickly muscles deteriorate. And most of these people are in their 20s and 30s. And so we say we fast forward, we take that in an individual in their 70s, and part of that progression might be this deconditioning. So really focusing in on that. Also making sure you're you're properly controlling or addressing comorbidities. So high blood pressure, high cholesterol, diabetes, smoking, all of those things, again, help accelerate how quickly someone progresses in MS. And then I think I'm on my last question. Okay. This one says, what's your take on hormonal birth control in MS? Do you recommend staying on birth control or coming off and using another means of contraception? I have PCOS and I'm concerned that being prescribed birth control was a band-aid on the issue to begin with. And now that I have MS, I'm worried that the birth control might do more harm than good. I don't have any concerns about being on hormonal birth control as it relates to MS. So if needed for other issues or reasons, I would say it makes a ton of sense. There is not any evidence that hormonal birth control worsens MS, worsens your chances of relapses, or worsens brain atrophy. In fact, for a lot of my premenopausal women, sometimes if they're having intermittent symptoms, we can see this correlation to when they have their menstrual cycles. In kind of these like pseudo flare recrudescence type pictures around the time of menstrual cycles, sometimes around ovulation. And our treatment choice for that is actually starting hormonal birth control. So I'm not too worried about it. Now, if you wanted to come off and use another means of contraception, also okay. What I would say, it's important to make sure you're on some sort of contraception when you're on any MS disease modifying therapies. Half of all pregnancies in the US are unintended. But I think that brings me to the end of my list.
Awesome. We had a couple more in the chat. These are 2 postpartum questions, and then I'll have another set after this. When would you recommend getting an MRI after giving birth? And if well controlled on Rituxan before pregnancy, would you continue on the maintenance dose or go up to the loading dose when you do the first one after giving birth?
Good question. MRI after birth, you can get it anytime after birth. Contrast in general, which depending on your neurologist, some do MRIs with contrast postpartum, some do them without. My bias is to do them without because usually most of my patients, as close as we can before conception is attempted, we try to get MRI scans. But there's not really a good time, I guess, necessarily to say you need one. If the plan is to restart disease modifying therapy postpartum, I might say you wait 3 months after restarting, just to reestablish your baseline. But if you're not restarting and you're using that as a means to determine whether you need to restart, sometime in the first 3 months would be ideal. And I already forgot the second part of that question you asked.
If well controlled on Rituxan before pregnancy.
Okay, perfect. So it depends on how far before you conceived your last rituximab dose was. So if it was over a year ago, I would recommend restarting loading doses. But if it was anything within the last year, I usually say you can just restart maintenance doses. Most individuals during pregnancy go into a relative B cell suppression state anyway. So if you're starting them soon enough postpartum, you're kind of maintaining that B cell depletion state.
Excellent. And then our last question submitted so far is, have you found that any e-stim devices help with building muscle strength in weak areas like psionic sleeves?
Good question. So the psionic neural sleeve, I think just came out a couple months ago. So it probably hasn't been long enough to see if it's actually helped with muscle regrowth. For those of you that are not familiar with it, I think it's actually kind of a cool device. Can they see my legs? It's essentially a sleeve all over. A sleeve that goes around from your mid-thigh down to mid-ankle, and it's got electrodes that go on different muscle groups. And essentially what it's doing is it's timing the stimulation of those groups with walking. So it's really helpful for people that have foot drop and then also like knee flexor weakness. So I think it's a neat device, and it can sometimes replace things like AFOs if you're an individual that uses AFOs. It is at a lower price point than like the Walk Aid and the Bioness, but still really expensive, also still not covered by insurance. So those are all things to think about. I think in general, what I have noticed is individuals that use functional electrical stimulation systems, so like any of those three I mentioned, you tend to be more active because you can be. And so that inherently helps with strength. I don't know that it's a direct correlation to the device, but it is allowing you to resume using the muscles that are designed to be used during regular walking. So I think there are some benefits there. I think the biggest thing to keep in mind, if those are things that you're considering, is to find a physical therapist that's trained in using those devices and try it before you buy it, because they're expensive. So the walk aids and the Bionesses, I think, depending on the model, I think are somewhere between 6,000 to 8,000. The neural sleeve, I think, is about 2,400, but then you usually pay monthly or every other month for replacement of the electrodes, which I think is around $30 to $50. So they're not cheap, and again, not covered by insurance. So just making sure you're trying them out. Where these devices fall flat, which I know wasn't the question, but important to talk about, is if you have hip flexor weakness, they don't stimulate those muscles of hip flexion. So if you have hip flexor weakness, that is a significant portion of your weakness, you won't necessarily see an effect.
Wonderful, thank you. That is all the questions that we have, and we are ending.
I think she's got one more.
One more.
Yeah, really good question. I'll repeat it really quick and then I'll answer. Her question was, I'm doing longer hikes, I'm doing more activity. At what point am I worried about doing these kinds of things to exacerbate symptoms or induce a new relapse? I'll answer that in kind of two different parts. So we know in general, so if I took somebody without MS, threw them outside in the 100-degree weather, they're going to feel lethargic, they're going to feel slow. And that's because your nerve signals all slow down in heat. And that's true for everybody. The issue with MS is if you're saying, hey, these pathways are a little tenuous already, and then I'm adding heat to it, it's kind of like having a car accident in the middle of rush hour, becomes even more prominent, right? That you're stuck in traffic. So it is really common to say, I am experiencing recurrence of my old neurologic symptoms in the setting of heat. Now, this can be in the setting of just a 1/4 degree increase in body temperature. It doesn't need to be much heat. So you can see it with some patients that say, every time I take a bath or a hot shower, maybe my vision dims where I had optic neuritis, or I see it with exercising, or I see it when I'm outside in the heat, or I see it with stress, right? Because stress increases body temperature. The key to that is knowing as long as it's a recurrence of an old symptom you've had before, I'm not worried about it. So even though it's a pain in the butt, that's kind of all it is, because it's not causing new inflammation, it's not causing new damage. Now, the most important thing with that is to say, can I make sure I stay cool before I get too hot? Because if you're just treating the heat, once you're already having those symptoms, you're trying to play catch up and it takes forever. What I might suggest is saying, if you know you're going on a long hike, right? Leaving early in the morning, which I'm sure you do. No, oh, you have to. Cooling towels, those like misting fans, because anything that increases evaporative abilities of the skin is going to help, right? Even throwing like a camisole or getting like a cooling technology like tank or bra, you can take that with you, put that on in the middle. All of those things are going to be really important. I love, and I promise I'm not paid by them, but I really love the cooling towels that you can get in Amazon. If you just search cooling towels, there's like a dozen of them. I just tell people to pick the one with the most reviews. But they're really nice because you just put them underwater, wring them out, and they have nice little Ziploc bags that they give you. And they usually come in like sets of 2 or 4, and they stay cold for hours. And when you put them on, they stay cold for hours. And you can put it around your core, put it around your neck, put it around your head, wherever you want, right? And make sure you stay cool before you get too hot. Now, that kind of stuff, I'm not worried about that inducing relapses, which becomes really important because I don't want you to not do those things. I mean, from a quality of life standpoint, it becomes important. But from an exercise standpoint, that stuff's all really good for you, really good for your brain. So I want you to do those things, but it's just how do I make sure that my symptoms aren't bad enough that I don't want to do it again, but I'm not worried about it inducing new relapses.
Awesome. Thank you, everyone.
Everyone.
We've posted the link for our evaluation form. Please do take a few minutes to fill that out. And we will be sending out this recording late next week. Thanks and have a great night.
Thank you.